Good morning. This talk's better than the skin cancer one. And actually, I had some people in the front row. We're going to talk about cosmetic surgery. I just put sleep on there to get everybody in the room. Now I'm going to try to reel you in. So that's Theunissen is actually how you pronounce that, although it doesn't look like it. And hopefully by the end of this talk, you'll understand why a plastic surgeon's telling you about sleep. Here are my objectives. I'm sorry if you can't see it in the back of the room, but it won't go any higher. My objectives are to introduce myself. We're going to talk about some sleep problems, what causes them, different treatment options we have. The one that I specifically do relates to jaw surgery, which we'll get into. I'll show you some pictures that hopefully are not too gory but interesting. And then the goal, while it's a sleep talk, is to actually keep you awake. The converse. So disclosures, when you go to these meetings, you always have to disclose. Nobody's paying me anything, but I do have an odd disclosure. I'm not a sleep expert at all. I know one little facet of it, and I did train for 12 years after college, so hopefully I know a little bit, but there are much better sleep doctors, which we'll talk about. I got a lot of my information from the AAOMS surgical update, and then a bunch is from my mentor who's out in California named Dr. Stephen Schindel. The true experts are those boarded in sleep medicine. There's actually a board that they have to pass to get that designation. It's usually internal medicine physicians, neurologists, psychiatrists, pulmonary critical care doctors. So those are the real smart guys. I did my residency in plastic and reconstructive surgery out in Nebraska, and then did a fellowship in craniofacial plastic surgery out in Stanford, and that's kind of why I got into this jaw-related surgery. So I'm kind of not smart, but I'm a good mechanic, and that's what you need when you want somebody to do bony work on your face. So what do? I do adult plastic surgery, including cosmetic and reconstructive, and then craniofacial, which involves a lot of pediatric kids work, and bones of the face, including the jaw. And some of the guys I worked with in California kind of pioneered this specific jaw surgery that we'll talk about for sleep problems. Just the kind of the breadth of craniofacial surgery includes cleft lip stuff that we close, cleft palate things that we close, facial trauma, accident victims, broken bones in the upper face and in the jaw. And then really bad stuff where we have to peel faces down and get to bones in weird spots. But really the idea behind this became, I think, with after treating people with both dentoskeletal abnormalities, just problems with their jaw and teeth, and then cleft lip and palate children who not only have a space that needs to be closed, but they also have restricted growth of their upper jaw. And like you can see, this patient has a setback or retrused maxilla, upper jaw, and so he's got a bad bite. And so after a workup and getting him into braces, we plan a surgery where we cut the upper jaw, kind of separate it from the mid-face, and over time distract it, pull it out. And we do that all through inside the mouth incisions after we've planned, and we pull it forward over time. And so we can take someone with a bite like that and give them a normal bite. So what we call a class 3 or underbite to a good bite, so that there's harmony with his bite and his face and his teeth. And so that's kind of the idea of the sleep surgery I'll talk about. But on to sleep, which is the reason that you're here. Sleep occurs in cycles. You've heard of REM sleep, your rapid eye movement sleep, and that's your most important sleep, but it comes in phases. It's the most important phase, like we mentioned, and in kids it's very important. That's when kids produce their growth hormones. So not only do you rest more when you're in that phase, but important endocrine and hormonal changes are going on. When you go to sleep, you should spend about 80% of your time in your bed sleeping. That's what we call efficiency. And then latency, ideally you should fall asleep within 15 minutes of getting into bed, and then you should enter REM sleep within about 90 minutes of getting into bed. And lots of people shake their heads when I say 15 minutes. Those are ideal situations. So if you look, sleep has really become a hot topic lately for a few very good reasons. If you look at Americans with a sleep issue, over 90 million will have a sleep issue. 40% of people over the age of 40 are snorers. And if you look at habitual snorers, which you snore most of the nights, and I'm sure a lot of you in this room sleep next to someone that does, 16% of those patients will have, or people will have, obstructive sleep apnea, which has again become really important and a hot topic as of late. Now the big picture is what they've dubbed SDB, or sleep disordered breathing. So that's all comers. And then a portion of those will have obstructive sleep apnea, which is what we'll talk about. You know, back in the day, it was I think it was just considered a nuisance. You didn't sleep well. People with OSA woke up, they fell asleep at stop signs and stoplights and at their desk at work. They snored. But we're learning that some terrible stuff is associated with OSA. So he's a bad guy, like that cartoon showing. High blood pressure, coronary artery disease, funny heartbeats, stroke, diabetes, behavior and cognitive problems, even acid reflux can all be explained sometimes by OSA. And we'll cover reasons for this. When you look at people with sleep apnea, then number one is always obesity. The vast majority of patients that do have this are overweight, but not at all is that a necessity to have obstructive sleep apnea. I've seen plenty of people who are too thin to have this condition. We explain it by your throat. You get fat just like you do on your neck or your bottom. You can get it in your throat. And then your throat, your pharyngeal walls don't work well. You get a smaller airway diameter and you snore. You get turbulent airflow. You don't get air in as well, and you get OSA. People get kind of, with obesity, it's kind of a vicious cycle in that studies have shown that if you get less sleep, then your brain tells you to eat more. So it becomes a thing where you get tired, you wake up hungry, you eat more, you get more tired, and it's a vicious cycle. So we got to break that. Another problem is tone. If you just look at the muscle in your throat, the muscle should be at a tone to where it keeps the throat open. It doesn't let it collapse. And things that cause decreased tone can give you obstructive sleep apnea and snoring. And that can be alcohol, drugs. Most of you may not, but I've heard of people in college that overdrink and then they snore. I'm sure nobody in here. Certain drugs do it. Your most common sleep medications, coincidentally or ironically, cause your airway tone to decrease. And so, again, you're kind of taking a pill that in the long term is kind of detrimental to your airway. And then it's also age-related. Unfortunately, as you age, you get less tone. There can be anatomic reasons. This patient to the right has a very set back jaw. And so anywhere along the airway from your nose to above where your vocal cords are can be a problem. We call them choke points or tight points. That's where there's not enough room. And it can be your lower jaw like this patient or your upper jaw like this patient whose maxilla, the upper jaw, is set back. So when she breathes, she doesn't have a nice column that air can go pass through. She's got a tight point that causes turbulent airflow. If we look at snorers, that's another vicious cycle in that the snoring causes vibrations in your pharyngeal, your throat wall, and then as they vibrate, they get more thickened, and then they vibrate more, and so that again, kind of the problem perpetuates the problem. And just a quick math blurb, I hate math, but if you look at a cylinder, if you make very small changes in the diameter, you get high changes in the volume. And so decreasing the diameter a very small amount can decrease the volume a lot. And so that's the problem. Turbulent flow, not smooth airflow, and the cycle. We're finding that sleep apnea is best treated at an early age. This cartoon says Generation X and then Generation XXXL, which is both funny and disturbing at the same time. Our children, we have 8 and 9-year-olds that are getting type 2 diabetes, and they're obese, and it's portion of their obesity could be from their sleep apnea, problems with tonsils, nose, whatnot. And we found that the cognitive changes are serious. These kids function at least a grade level lower than they should. So these normal smart kids are not doing as well as they should. So just like when you go to any other doctor for any other problem, our evaluation of your airway starts with paperwork, unfortunately. But we have you fill out a questionnaire, and it's what we use is the Epworth Sleepiness Scale, and we can kind of, as a very subjective manner, determine if you're at risk for OSA. Do you fall asleep, sitting up, at stoplights, whatnot? So you fill out this form, then you get clinical examination. We look at you, we check your mouth, look in your nose, all this kind of stuff. Then if we need, we get x-ray studies. Kind of the important ones are a lateral cephalogram, which we'll get into, but that's just a picture of the bones from the side. And then a really fancy CAT scan, which is called a cone beam, which is you kind of sit in it, it shoots images from you. Your dentist and orthodontist commonly have these. And then we can use software that shows us 3D images of your airway. And then we have to have a big fancy word for everything, a polysomnogram. That's just a sleep study. So then you get a sleep study. When we're looking at airways, this is a CAT scan of someone's face, and you can tell by the diagram it's pointing out the septum, which is the structure in the middle of your nose, your turbinates, which everybody has, and you can have huge turbinates that can cause airway problems, or you can have a deviated septum that can cause your air problems. We also look at your face. Do you have one or both jaws? Are they set back? We look in your nose and we look in your mouth. So here's an example. This first upper left picture looks relatively normal, but when we really use a speculum and look inside, you can see the left side of the patient's nose is blocked, and that's a septum. That's a deviated septum. So this patient's not getting good air down. His obstructive sleep apnea may be from as simple a cause as his septum. Sometimes our ENT colleagues use a little more invasive instrument. Yeah, which nobody ever gets in line to have this, but they stick that thing down your nose and take a good peek. I've heard it's not fun. And then your intraoral exam, it may not be your throat at all or your lower airway at all. It may be huge tonsils that are blocking your air. And a lot of times, people, the first line physicians and doctors that people see are dentists and orthodontists because they think they've got a tooth problem, and they go in and their teeth malfunction or abnormality is a manifestation of their sleep apnea. So these guys see it commonly on the first line. So here's the fancy imaging I was talking about. This is a cone beam CT scan with 3D software technology. So it's really neat. In a couple minutes, you have a picture of the patient's airway. So you can see, I can tell where you have a blockage, where is your airway constricted. And then if you know that, you can guide treatment accordingly. Now, polysomnogram is the sleep study. It's best done at an overnight center. Where I trained at Stanford, they had a sleep center at the Four Seasons. So you would go get a spa day, you get a room at the Four Seasons, and so the Bay Area, California is slightly different than over here. Maybe you get a Hilton or a Motel 6. Just kidding. But it's best done in an overnight sleep study, and they look at all these things. We look at the pressure in your esophagus, the tube that goes from your mouth to your stomach, your oxygen saturation. They look at your heart while it's happening, what position you sleep. They record you to see if you're talking, if you get up and walk. The video recordings of these are sometimes hysterical. It's like someone's wrestling with an invisible person in the bed. And then your respiratory rate. What we found that some people have such bad obstructive sleep apnea that they suck in so hard to breathe that the pressure in their airway gets lower than the pressure in their esophagus, which brings up gastric fluid and gives you heartburn. Your oxygen levels can fall so dramatically that it affects the beating of your heart, that you get funny funny arrhythmias, funny heartbeats. So part of the reason this is neat is because it all makes sense. It's all fairly logical when you think about it. Just some technical points. After your sleep study, basically we look at RDI, which is your respiratory disturbance index, which should be less than 5 in adults. Kids should be 0. Or your AHI, your apnea-hypopnea index, which is how long you stop or barely breathe. And it has to be an episode for 15 seconds. And there's patients that will have 100 of these episodes at night and not breathe for almost a full minute. It's so bad. And then we kind of break it down into mild, moderate, and severe. So, in summary, that's a lot of fluff, I believe, all to tell you this. The exam and the imaging tells us where the problem is. Is the problem your nose? Is it behind your palate? Is it behind your tongue? Or a combination of those? And then the sleep study tells us how severe the problem is. So I think it can be broken down into relatively simple terms. Then, when we know what the problem is and how bad it is, then that guides our treatment. So it's logical. Treatment. I broke down treatment into 2 areas, non-surgical and surgical. I'm a surgeon, so I like to focus on the surgical, but the vast majority of you in here will never need a surgery for your sleep apnea. You could be helped with non-surgical means. Cpap, show of hands, has anyone heard of or everyone heard of Cpap? We'll cover that. There's different oral appliances. Sleep hygiene, which will hit home for most of you and seems like common sense, but a lot of people don't follow good sleep hygiene, and that fixing a small problem in your hygiene and your preparation to go to bed could make a huge difference in your in the quality of sleep you get. When we talk about surgical, I kind of break them down into soft tissue procedures. So surgery on soft stuff in your throat, bony stuff, surgery on bones, and then miscellaneous. So here's CPAP, continuous positive airway pressure, and it's clearly an excellent first-line treatment for obstructive sleep apnea. Now, is it fun? I've heard it's kind of the air version of waterboarding, in that this continuous air is forced into your nose, mouth, whether you ask for it or not. You just put the machine on and you get it. Now, it can be titrated, low to high levels, and compliance is the issue. There are some people that are fine with it, and some people are miserable with it. I think across the board, it's not surprising, but women tolerate it better. Y'all are tougher than men, for sure. But if you can tolerate for 70% of your sleep at night, then you're doing well. And it's funny to me, in all the pictures of sleep apnea, everybody looks like they're just in heaven, like they love it. They couldn't be happier with this big bulky thing on their face. And it works by physically forcing air in there to keep your airway open so that you can get better, more smooth columns of air into your lungs and a higher oxygen saturation. So that's CPAP. I definitely don't mean to knock it. People do very well with it, and it's clearly an excellent first-line treatment. What has gained some favor as of late are these MRAs. They're mandibular repositioning appliances, and this guy named Thornton has this version. What it does, you can go to Walgreens, I think, and get some little kits that you maybe boil, and then you put it into your teeth, fit it in, and then you're good to go. So you can get off-the-shelf ones, but the right way to go is to get molds taken of your teeth, and then what this thing does, it's basically an upper and lower retainer that forces your mandible, your lower jaw, forward and opens your airway. Here's another Somnodent. That's another version that's kind of fancy. But you need to determine your severity. So after a sleep surgery, if you're a mild to moderate, then you may be a candidate for this. If it's severe, I wouldn't use it. You go to an appropriate dentist or orthodontist to get a good one made, and it does very well with primary snoring. Sure.
Do you use it on the top if you have a recess or on the bottom, or both?
Both. You need both the upper and the lower because you're holding your lower jaw out with the upper. Kind of anchors and holds it out to length. And then some are advocating you get a sleep study after this thing to see how much, objectively, how much it's improving your numbers on your sleep study. Now, if you have joint problems, TMJ problems, it's kind of contraindicated because you are forcing the lower one forward, and that's putting pressure on your jaw. So not a good thing to use if you have TMJ problems. And you should be followed periodically. You shouldn't just get it and then sleep with it every night and then never see anyone again. It can be, they say 6 months, every 6 months. Whoever fitted you for it, dentist or orthodontist or sleep doctor. So it does pretty good. I mean, half of the people will get better with it. Primary versus rescue means, do you use it alone or do you use it with a Cpap? And to me, that sounds terrible, having your jaw thrust forward and this big mask on your face. How do you sleep with that? And again, if there's a treatment where you have to be tough to take it, you do better than men, which is embarrassing. Complications, dry mouth, it can move your teeth, TMJ discomfort, and muscle pain from wearing it. So sleep hygiene. This is this should be more slides than it is, but it's logical. It should be common sense, and that is, we get ready for work. We prepare for certain things, and if you have problems, you should be preparing for sleep. It's a good idea to exercise, even if you're walking. Exercise and do it early in the evening. Diet. Avoid chocolate. Don't have one of these right before you go to bed or after dinner. That makes sense, right? My granny drinks coffee before she goes to bed, and she doesn't understand why she doesn't fall asleep quickly. So that makes sense, right? Preparation. We should all, yes ma'am. Mm-hmm. Yeah. Early evening or early morning is ideal. Yeah. I would do it before, an hour or so before dinner, and then we'll get to where you diet. But it's kind of nice. It's not like you're exercising so that you're physically tired and fall asleep earlier. It's you're exercising to stress your body so that it has to recover. And it doesn't matter if you do it before work or after work. As long as you do it, you'll sleep better. Diet, you should really have nothing but water an hour or more before you go to bed. It's nice to have an early dinner, get that digested, have some water before bed. And then, I read this. I have nightmares actually about this book because my kids, I read it and I think it's going to help them fall asleep, and it doesn't. But you should read the old-fashioned way, not with your computer or your iPad, because then you squint and you get a headache and it's harder on your eyes. And so light TV is very second. I would read first, because if you're watching the news and hearing about all the gunshot violence on Airline Highway, that doesn't make me want to fall asleep. It makes me want to buy a gun. So, moving on to surgical treatment. I split up my surgical treatment into soft tissue surgery. So, surgery on soft stuff, and then bony, surgery on bones. This is it's called the UP3, UPPP, the big word of it, uvulopalatal And this is a very, that's a mouthful?
That's surgery.
I did it. I was nervous with the camera on, but I got it. This is a big word for something kind of simple. You're basically cutting out all those things that we listed. You're cutting out your uvula, the punching bag in the back. Sometimes you're decreasing the length of the palate, so you're moving some of the palate. Some people also address the tongue at this point, but not that the last group gasped, because I think I said it incorrectly, but just not like the length of your tongue, just a portion, usually the base of the tongue, shaving that down. They commonly use lasers now. It used to be they just lopped it out with a scalpel, but now you can laser ablate it. Either way, I think it hurts. And this is a patient afterward. So he's had his uvula removed, some of the palate shortened, and this is definitely the most studied and commonly performed surgery for sleep. And then I think years and years and years ago, everybody got very excited about it. It was hot. It was going to change your life. It was going to make you sleep like a baby. And then it wasn't. You know, not everybody got better. And now it's kinda. You know, there's a definite place for it, and it all depends where the problem is. If you have a narrow airway behind the palate, then this may very well be the operation that you need to get better. It is associated with complications. You can get poor movement in your palate, which can help you or cause you to have air escape through your nose. So what we call velopharyngeal insufficiency, which another big word for just air escape from your nose. Your palate's not working normally. You can get stenotic. It can get too tight, and then sometimes there are patients that have to have it released, opened up wider, and then you can have pain swallowing. So it's not without its problems, but it is a good operation. If the problem's behind your palate, that's probably the one to have. But you know, it's not a catch-all. I think as we learn more and more about sleep, we get better and we get happier patients because we're not just doing one operation for a bunch of different problems. So now on to the fireworks. This is all of this to get to my little one area of sleep surgery. What I do is MMA. That's mandibular maxillary advancement. And so simply it's cutting this upper jaw and cutting this lower jaw and moving it forward. We use plates and screws to hold everything out in place. I'll go through some of the recovery and steps of the operation, but the vast majority of the time we can do it through all incisions inside the mouth, so nothing on the face. Every now and then it's tough to get some screws in, and so we make just a little stab incision under your jawline to get, it sounds kind of barbaric, to get the screwdriver to your bone to screw your screw in. I know, that sounds fun, huh? It's like a massage. For sleep, we're typically bringing both of them forward, right? The question is, and this has been, portion of this was pioneered by some older guys in California, and the knock on it is that we don't know exactly how far to move someone forward. We do know, like from our last slide, that small increases in the diameter of a cylinder cause huge increases in the airway. So typically, the motions we're talking about are 10 millimeters for the upper jaw, and then the lower jaw follows suit to fit into wherever it needs to be. It's indicated for severe OSA. So like I said, most of you in this room need to walk in the morning, avoid caffeine in the evening, read Goodnight Moon, and you'll be okay. But there may be one or two that are just miserable, and they've tried everything, so then they're a good candidate for this. With everything, this is life, so there's good and bad news, right? The good news is you get your jaw wired, or at least partially wired, for amount of time, so you will lose weight whether you want to or not. Most people could afford to lose a few pounds, so that's good news. You get straight teeth. Ideally, we have you placed into braces before and after so that we can both correct small errors or asymmetries in your bite, as well as have something to wire everything into. So it's nice to have braces. And then you sleep better. So who wouldn't be happier, a little lighter with better teeth, and if they slept like a baby every night? That's why I like to do this. The bad news is it's invasive. You know, this is, I'm using a saw to saw your bones, cut them, and move them forward. There's a hospital stay, one night in the ICU. You're taking a patient who has a bad airway to begin with, and then you're operating on them. And there's swelling and all kinds of inflammation that goes along with surgery. So I watch you in the ICU your first night. I want around-the-clock care to make sure if you have an airway problem, we can address it. And then 1 to 2 nights in a regular bed on the hospital. Usually the women 1 night, the guys 2 or 3 nights. So, yeah. So it's an investment. It's a big investment. Out in California, it's also a financial investment because a lot of these guys don't take insurance, so people just write checks for this stuff. But around here, we're still taking insurance. So ideally, you go to a sleep doctor, of which there are some great ones in town, and I can give you names. They get a sleep study. You try your Cpap, you either love it and you're done, or you hate it. You try soft tissue procedures, mandibular repositioning devices, etc. You're at the end of your rope, you're ready to explore other options. So then you come see me. I do an exam. I may get a CAT scan to look at your airway, and we discuss the operation. I tell you that we're going to cut and break your upper and lower jaw. We're going to use plates, titanium plates and screws to hold everything in place. We're going to wire your jaw closed, and I typically use elastics, which are a little better than actual wires to wire everything down. I tell you, we're going to spend 2 to 3 nights in the hospital. You're going to have significant swelling. You're going to look like a chipmunk for the first week. Then after that, it'll starts to go down. Kind of like if you've had your wisdom teeth out and you swelled after that, just much, much worse.
So what do you feed them? Do they eat?
Yeah, no. You definitely get to eat. For the first 3 weeks, I do a liquid blended diet, and for the next 3 weeks, soft, non-mechanical diet. So mashed potatoes, eggs. Yes, I've had people put hamburgers in the blender just to get it down. So there's a potential change in your facial appearance. Your nose kind of rests on your upper jaw, and we're moving that. So you can have small changes in facial appearance. We have tricks and techniques to counteract those changes, but quite frankly, some people have set back upper and lower jaws, so they kind of look better after this. And the diet, you beat me to it. So then you're still not done. I still have not talked you out of this, and you still want to proceed. So you go see my oral surgery colleague because I do this. This operation is done best in a team, so you have 2 surgeons with you. My preference is an oral surgeon in town. You meet him. He takes dental casts. He gags you with that terrible stuff that you got a retainer with, but it's temporary. We make casts, and then we can plan out your surgery, the cuts, the advancement, and we can make you a little retainer splint, something we call a surgical splint, which we wire to your upper teeth so that your lower teeth fit in nicely and your muscles can get used to the new position of the jaw. Then you're still not done. Hopefully, you visit your local friendly orthodontist like Tom Cruise did later in life and got braces. The other option is that we use temporary braces like we do with broken faces sometimes. We wire these in. So I have done it this way. It's kind of, it's more ideal to have braces because after surgery you can't manipulate teeth with you if you just have arch bars or temporary braces in place. So your bite after surgery, what you get is what you get. There's no shifting teeth if we need. And then the results are excellent, greater than 90% success rate, either getting off Cpap completely or a significantly lower setting. Patient satisfaction is high from this, and that's one of the reasons I enjoy it. I like surgeries that make sense, and I like surgeries that make people happy. So then I'm happy. It is a big investment, but it's also a big reward. As you can see, you get bounced around all these places, but at least you know what you're getting into before you get into it. So that's my spiel on mandibular maxillary advancement. There's miscellaneous procedures such as gastric banding, gastric bypass. There's even reports of people getting tracheostomies, voluntarily getting holes in their throats because it's actually a great treatment. You make a hole right here and you bypass any kind of airway problem that you have. The air goes right in. Now a trach is not without its own list of complications, and I have to believe that most of the literature for this is from Europe and overseas where they do different things, because I don't know that I've ever seen a patient who was ready to sign up for this. I just stay awake at night, So in surgery, I want you to know that, obviously probably everyone or most everyone in here will never see me standing over them with a saw cutting their jaws, but options do exist. I don't think that you should spend your life miserable not sleeping. I have a 2.5-year-old and a 14-month-old, and so I know how not sleeping feels, and it's terrible. But I'm weak. I'm the weaker sex. My wife probably does fine. I think a good physician boarded in sleep medicine is the bus driver. That's the key. And like I said, there are some definite good ones in town. We're in a perfect area. This is very hot on the West Coast as a treatment, and I think there's very few of these procedures being done here, and we have the population that fits these criteria and that would do well with it. I've only been in town 6 months, and I'm really hoping that this kind of takes off and is an option for everyone. And then, as with anything, if you go to a doctor and he accurately identifies what's wrong, where it's wrong, then you can treat it, and that's how this works. So then you get the correct treatment, and everybody's happy. Unfortunately, this is a picture. It's supposed to be a picture of my daughter. She fell asleep in her jump thing. She just crashed and sleeping over. So close your eyes and imagine that. But that's supposed to be there. It didn't work out.
Is that her name, Riley?
Yeah, that's her name. So that's the end. I think.